So just some housekeeping. The webinar will be recorded and that'll be uploaded onto the Cancer Academy. Your cameras are turned off and your microphones are muted, but we would encourage you to share any comments or questions in the Q&A box at the top of your screen as opposed to the chat box. Next slide. So a couple of introductions. It's my pleasure to invite Dr. Arvind and Jeff to our webinar this afternoon. They are both experts in their fields as consultant haematologists over at Clatterbridge Cancer Centre. Next slide. Arvind is going to give us a little bit of anatomy revision and work through lymphadenopathy, splenomegaly, and when we need to worry or refer our patients. And Jeff is going to explain what happens when an urgent suspected cancer referral lands, giving some case examples from a clinic of process and outcome, and looking at common issues that may arise on treatment or indeed after treatment, and looking at some key learning points. Next slide. So I'll hand over to Arvind. Thank you.
Thanks, Debbie, and thanks for asking me to give this talk. So as you've kindly, from the previous slide, I'm just going to talk a little bit about the lymphatic system, then talk about lymphadenopathy, splenomegaly, and when to refer and when to worry with regards to suspicion of an underlying lymphatic or more widely hematological malignancy. So these two pictures actually illustrate the lymphatic system. So the lymphatic system very briefly comprises of lymph nodes, and each of us has about 600 lymph nodes scattered in about 30 areas throughout the body. Additionally, we do have secondary lymphoid organs and also the spleen. Of course, the areas in the body where lymph nodes can be felt most easily is the neck, armpits and groins, and the spleen, of course, if it enlarges, should become palpable below the left costal margin. The diagram on the right is actually a pictorial representation of a lymph node, and I think illustrates actually that lymph nodes in their own right, although very small, are actually quite complex organs and consequently can become enlarged or behave abnormally in many circumstances, not just in the setting of cancer, or either hemic or non-hemic. Next slide, please. So lymphadenopathy broadly refers to lymph node enlargement of any cause. In fact, there are literally hundreds of individual causes of lymphadenopathy. These can broadly be divided into the following list. There are, of course, the usual suspects there, and probably in our practice, the commonest cause of lymphadenopathy that we see is either infection or inflammatory. An infection, particularly in young patients, is usually viral, such as EBV or CMV infection. Metastatic malignancy, of course, can manifest as lymphadenopathy. So, for example, axillary lymph nodes being the primary mode of presentation for metastatic breast cancer. And then lymphoma and other lymphoproliferative disorders can also present, most commonly present, with isolated or generalized lymphadenopathy. Thereafter, it's a list of things which you would expect but are relatively uncommon. So primary immunodeficiency, some drugs, including quite old and not very frequently used anti-seizure medications, some rarer disorders such as sarcoidosis. I put skin disease on there as well because we do not infrequently see patients referred with generalized lymphadenopathy where the underlying cause is actually uncontrolled or poorly controlled skin disease such as generalized eczema or psoriasis. And in these patients, it's usually fairly evident because they tend to be systemically quite well, but have low volume lymphadenopathy palpable in areas where the skin is stirred up. Next slide, please. So broadly, lymphadenopathy can be divided into localized or generalized. Most of the causes are really exactly as you'd expect. So neck lymphadenopathy, particularly in young people, is almost always caused by viral infections, most commonly EBV or CMV infection. Though, of course, there are many other causes, including metastatic malignancy, most particularly head and neck cancers, lymphoid cancers, other types of infection, including bacterial or toxoplasmosis. Axillary lymph nodes is a relatively common mode of presentation for metastatic breast cancer. In our practice, we do also see patients presenting with inflammatory or autoimmune joint disease. So, for example, rheumatoid arthritis or psoriatic arthritis, which then gives rise to axillary lymph nodes because of upper limb disease, dermatopathic nodes, and finally, of course, lymphoma can also present with axillary lymphadenopathy. Inguinal lymph nodes are actually probably a point of consideration in their own right, because low volume groin nodes are more or less ubiquitous in the adult population, and it's believed that this is because of subclinical infections in the lower limbs and also the groins that we acquire through the course of life. And consequently, we tend to worry less about groin nodes unless they get to, for example, 2 centimeters or are rapidly progressive, because more often than not, groin nodes tend not to be pathological. Next slide, please. So generalized lymphadenopathy can also have many causes, including viral infections, autoimmune conditions, granulomatous disorders, and lymphoid malignancy. So it's essentially the same list of causes as localized nodes, but in this setting, patients sometimes can have generalized but fairly symmetrical proportionate lymphadenopathy, or you do on occasion get situations where patients can present with disproportionate or asymmetrical lymphadenopathy, and that can be an alarm symptom that something sinister is going on in a given area in the body. Next slide, please. So how do I approach a patient with lymphadenopathy? So as always, the history often gives very helpful clues. In young people, particularly, if there's a fairly short history, really you'd be suspicious for the presence of a viral infection. So, for example, primary Epstein-Barr virus infection. Symptoms can be helpful, though not always. Of note, actually, only about a third of patients with lymphoma actually present with the classical B symptoms of persistent drenching sweats or unexplained weight loss. So symptoms can be helpful if present, though the absence of symptoms doesn't necessarily exclude an underlying sinister disorder. And I guess it's worthwhile asking about obvious precipitants as well. So particularly in the context of recent travel, giving rise to generalized lymphadenopathy, high risk behavior, and of note, medications. This is really fairly small print stuff, but is recognized and we have seen it, can sometimes give rise to lymph nodes as well. These are much less used nowadays. So we have seen in the past patients on some of the older anti-epileptic medications, for example, phenytoin, but also more recently, more commonly used drugs in contemporary practice, such as sodium valproate or carbamazepine, are recognized to cause low volume lymphadenopathy, which tend to subside on withdrawal. Um, uh, in terms of examination, the things I tend to look for are size of lymph nodes. Usually for neck axillary lymph nodes, 1 centimeter is generally regarded as being significant. This is not the case for inguinal lymph nodes, where, as explained earlier, are very common in the adult population. So generally for these, we tend not to worry till they get to at least 2 centimeters, unless unless of course there is obvious alarm symptoms associated with these. Asymmetry can be helpful. So if, for example, someone has small lymph nodes on one side of the neck, but a palpable 3 or 4 centimeter lymph node mass on the other side, that would certainly be suspicious for a neoplastic process in the absence of a reactive cause. So that's also worth looking for. Location of lymph nodes can be helpful. So once again, inguinal lymph nodes, which are small, tend almost always to be reactive. But for example, supraclavicular lymph nodes are often pathological, not necessarily malignant, but often can be pathological. Of course, it's important to perform local examination in the setting of localized lymphadenopathy. So, for example, in patients with localized axillary lymph nodes, is there a breast mass? Or some potential, an axillary abscess or something like that, really. And finally, of course, the presence of associated splenomegaly can be very helpful. Once again, of course, these can be seen in viral infections, but lymphadenopathy associated with splenomegaly, particularly if persistent, often signifies the presence of an underlying malignancy. Next slide, please. So when do I worry about lymphadenopathy? Some of these criteria are actually lifted from the old NICE criteria and are also present on the CMCA referral proforma for suspected lymphoma. So these include persistent lymphadenopathy, which no underlying obvious precipitant, uh, uh, as you'd expect, progressive lymphadenopathy or splenomegaly. Patients with low blood counts may actually probably should have a lower threshold for being investigated because they may have a bone marrow failure or some other immune-mediated cytopenias. Once again, symptoms can be helpful if present, but are often not present and often also very non-specific. And finally, of course, it's helpful to look for the presence of obvious sinister clinical signs or symptoms. So, for example, in a patient who has a smoking history and has neck lymphadenopathy, you may be concerned about the presence of metastatic lung cancer, for example. So these are the things which would normally make me worry if patients have lymphadenopathy. Next slide, please. So what tests can you do in primary care? So as always, these should of course be influenced by history and examination findings, but tests which generally can be helpful and I would advocate should be performed in everyone and anyone unexplained lymphadenopathy is a blood count. Particularly looking for the presence of a raised lymphocyte count, because this may, for example, be a mode of presentation for, say, CLL. Routine biochemistry. Immunoglobulins is a crucial test in patients with a monoclonal paraprotein in the setting of lymphadenopathy are likely to have an underlying lymphoma. So it's always worthwhile doing. And finally, we always screen all patients for HIV in the presence of lymphadenopathy, either as a new presentation or for otherwise persistent unexplained symptoms with lymph nodes. And actually of note in the clinic in any given year, we do pick up 2, 3, 4 patients with a hitherto unknown diagnosis of HIV, and then refer these patients on to our colleagues in the HIV and ID teams. Of course, the crucial test whenever malignancy or a sinister cause is suspected is a biopsy, and it would be a good idea to consider referral following your local pathways based on appropriate specialty. The next stage of test potentially could be done in secondary care, and these can often be based on symptoms and also which should then potentially instigate referral to an appropriate specialty. So, for example, if someone has got poorly controlled joint disease, consider referral to rheumatology, and so on. Imaging is indicated in the presence of any worrisome features. And I think if you're worried and thinking about referral, then this can be performed in secondary care depending on level of access you have to imaging. Generally, our go-to test is CT scanning in patients that we are worried about, though in some instances, ultrasound may be a perfectly reasonable modality, particularly in the setting of low volume or isolated nodes in the absence of any other obvious alarm symptoms. Next slide, please. So in terms of referral, once again, please follow your local pathways. Generally, we always advocate referral to ENT for patients with neck lymphadenopathy, and patients with axillary lymphadenopathy should be referred to local breast team. For patients with generalized nodes, it is reasonable to consider referral to hematology, though worthwhile also considering referral to other medical specialties depending on clinical circumstances. At the moment, for groin nodes, there isn't really a clearly defined pathway, though we are working on that. But generally, once again, it would be helpful to refer to whichever specialty in your local area which is able to conduct a biopsy. Usually, this increasingly nowadays, these are imaging-guided biopsies performed either under ultrasound or CT guidance, though on occasion a surgical biopsy may be merited. Next slide, please. So moving on to splenomegaly, many of the causes of splenomegaly, as you'd expect, do overlap with causes of lymphadenopathy. So splenic enlargement can occur for many reasons, and actually in our practice, probably the commonest cause of borderline spleen size that we see is actually probably liver disease or portal hypertension. Of note, there are actually quite a number of published studies, quite big studies, in fact, which have looked at spleen size, and it's clear from published evidence that in our own practice that there can be a very wide variation in what constitutes a normal size spleen. Of note is actually that there are online available splenic size calculators, and the one which I use in the clinic is on the QX app, which is freely available. And we do see a reasonable number of patients referred to us with borderline spleen sizes, usually detected completely incidentally on imaging performed for unrelated reasons. And quite often, actually, the size of the spleen does tend to correlate with height, weight, gender, and also sometimes BMI. Next slide, please. As you can see, the causes here are pretty much as expected, and do tend to overlap with causes of lymphadenopathy. A couple of additional things are, of course, liver disease or portal hypertension. Also, of note in patients with high blood counts and splenomegaly, you should have at least a low threshold for thinking of conditions such as polycythemia vera or essential thrombocytosis. And thereafter, we're sort of getting to fairly small print stuff. So, and these include things like hemolytic anemias, chronic hemoglobin disorders. But of note is that these patients will almost always either be known to a hematologist or previously known to a hematologist, so that a diagnosis should be established. Next slide, please. So in terms of an approach to splenomegaly, so by some distance, the most important thing from my perspective is whether or not the spleen is actually clinically palpable. In patients who are referred to us with splenomegaly discovered most commonly incidentally on imaging, I tend to worry much less about it if I can't feel the spleen. Other things I look out for, I tend to ask for is anything which might predispose to the presence of liver disease, and also on examination will look also for the presence of associated lymphadenopathy. And once again, lymphadenopathy and splenomegaly with no obvious underlying cause should really make us think about the presence of underlying lymphoma or related condition. Next slide, please. So when do I worry about lymph nodes? Well, firstly, when do I worry about splenomegaly? As just discussed, it's when I can feel the spleen. If I can't feel the spleen, I tend not to worry about it, particularly in the setting of normal blood count. So the things to look out for that would make you worry about spleen would be if the patient had an abnormal blood count which is unexplained, so either high or low blood counts, if they had associated persistent palpable lymphadenopathy, or indeed lymphadenopathy on imaging. Uh, Also, if imaging has demonstrated the presence of unexplained focal lesions. In many instances, these may be simple cysts, but if imaging demonstrates the presence of unexplained focal lesions, that should certainly make us worry that there's something sinister going on. Finally, progression over time may be relevant as well. So a degree of normal variation, of course, is acceptable, particularly when ultrasound is used as the imaging modality because ultrasound is dynamic and operator dependent. Nevertheless, if there is a clear progression over time in the absence of an obvious precipitant, that should also provoke further investigation or referral. Next slide, please. So assessing spleen size is useful. By some distance, the best validated modality in terms of published studies is actually ultrasound, which of course is non-invasive, relatively cheap, doesn't expose a patient to radiation. However, it can be dynamic and to a significant extent also operator dependent. So cross-sectional imaging can be helpful, particularly in characterizing focal lesions. But of course, these are more resource intensive, and in this case of CT, also exposes the patients to a significant amount of radiation. So usually speaking, in the absence of any alarm symptoms or signs and no other obvious blood count abnormalities, ultrasound is usually more than adequate as a modality of investigation. Next slide, please. So what test should we do for investigating splenomegaly? So I just similar to little lymphadenopathy, it's always sensible to do a blood count. And the things we'll be looking for is the presence of a raised lymphocyte count or otherwise unexplained high or low blood counts. I would always advocate performing immunoglobulins and having a very low threshold for referral if a monoclonal band is present, because this is likely to be lymphoma or some other lymphoproliferative disorder. And thereafter, further investigations are guided by clinical findings, and these may include, for example, a fibroscan, because these are particularly in patients where an ultrasound scan, for example, has shown fatty liver, but with hitherto no known diagnosis of liver disease, and actually probably I would say on 2 or 3 occasions per annum, we do pick up patients with no known previous diagnosis of liver disease, borderline spleen size, on the basis of fibroscan, who we then refer around to our colleagues in hepatology. The further tests, of course, then, if there are any worrisome features, will then should be done in secondary care, and these include CT scanning, and in the clinic potentially we may also perform molecular screening or bone marrow aspirate and trophine if we're sufficiently worried about an underlying malignancy. Next slide, please. So I was asked also to do a slide on what we find helpful in referrals for suspected malignancy. And I've made a small list of things here. Of course, history and examination findings are helpful. If possible, it would be helpful also to include a blood count result, particularly if a lymphocytosis is present. Additionally, we do find it helpful to know if the patient has a paraprotein. Of course, paraproteins are most commonly associated with myeloma, but we do see paraproteins associated with low-grade or rarely high-grade lymphoma, and these tend to be IgM paraproteins. So if a patient with lymphadenopathy or splenomegaly has a paraprotein, it's a very high likelihood that they have lymphoma or other related condition. Next slide, please. So in summary, there are many causes of lymphadenopathy and or splenomegaly. Of note is that many of these tend to be self-limiting or have a clear underlying reactive precipitant, and this may include infection or inflammation. However, if you're worried because the patient has got some alarm symptoms or signs, or there are persistent unexplained findings or on clinical grounds or on investigational grounds, then please have a low threshold for referral to secondary care. Thank you. That is my section of the presentation. Thank you.
Thanks, Arvind. So I'm Jeff Smith. I'm another consultant haematologist at Clatterbridge. I'm just going to take on discussing the next steps, really. So Arvind's very eloquently described the sort of initial presentation, investigation, the lymphadenopathy and splenomegaly. So what I was going to do is try and go through what happens when we actually receive referral for query cancer, 2-week referral, and then use case examples and illustrations, really. So from patients we've seen in the clinic, as a sort of the process and the outcome, and then discuss common issues that may occur, and then summarize. So next slide, please. So just a few statistics to begin with. So first of all, 7% of conversion for GP referrals to cancer occurs in terms of 2-week waits. We have about 2,000 new Hodgkin's lymphoma and 13,000 new non-Hodgkin's lymphoma per year in the UK. I think as Arvind's already said, broadly speaking, the referral pathways would be neck nodes to ENT, auxiliary nodes to the breast team, and then obviously other areas would be to other specialties such as haematology. And the rationale for that on national pathways are really because things like breast cancer or head and neck cancer are far more common in reality than lymphoma, and they need surgical treatment. And if lymphoma is diagnosed by coincidence by these teams, then we have good channels across referral that exist already with these specialties. So we're able to see the patient fairly quickly and promptly. And lastly, as well, these teams as well are very helpful when we need surgical biopsies. So it's quite helpful for them to go to those specialties first. Next slide, please. So in terms of what happens when we see patients, so at Clatterbridge, we're quite fortunate. We've got a rapid diagnostic clinic that we set up a couple of years ago. It's a joint clinic next door to the head and neck department, where they have an RDS as well. So that's what I said about we do have good fostered relationships with them. So if we receive a referral, we'll obviously see them in clinic, we'll carry out a clinical review, history examination, etc. In terms of what we can do on the day, we can do blood tests on the day, we can get access to an ultrasound plus minus FNA, and we can also do same day bone marrow and aspirin to refine as well, if we wish to. And then following that, on this rapid diagnostic clinic, we've got next day CT scan, or if we want to do a PET scan, it's as per the national contract within 5 days. And then lastly, we've got access to core biopsies. The aim a couple of years ago when this was set up to try and get the core biopsy done within 48 to 72 hours. So that's something we're still working on. I think in reality is for IR, it's quite difficult to achieve this, but it's certainly something as a group we're trying to work towards. So that's the kind of process that happens when the patients come to clinic. And it does mean that we're able to, for the majority of patients, we're able to tell them quite quickly from a faster diagnosis perspective whether they think we have cancer or not. The key part is if you need a biopsy, that's the sort of, well, perhaps delaying factor, if you like, because that is it's more difficult to organise, and obviously then you have to wait for histology to come back. So next slide, please. So I thought we'd do is just go through a few cases, just to illustrate the types of things that we get and what the kind of consequences of investigations are. So the first case is a 25-year-old female. She's got groin nodes. So as a consequence, she's referred to haematology, and we saw her in the clinic. First of all, noted that she was quite slim. And I would make note that people who are slim, it's very often easy to feel groin nodes. In the groin, they can often be up to 1, even 1.5 centimeters in size and not be pathological. and it's quite a common thing that we do see. So in clinic, thought it's unlikely to be anything significant, anything sinister, but we were able to send it down for an ultrasound on the day, predominantly for reassurance. And sure enough, the ultrasound was reported as reactive features with prominent but non-pathological appearances on ultrasound. So this is really an example of a non-cancer diagnosis. So we're able to tell her on the day that she doesn't have cancer, and we're able to discharge her on that day. So I put the bottom there about if she has sweats, does this matter? And what I would say is the answer to this is no, essentially. We do see a number of referrals of sweats, and most of the time it's not pathological. It's not related to lymphoma. So I know sweats is one of those sort of classical B symptoms as always described, etc. But the reality is most of the time it's due to endocrinological causes or medication. We know about 0.5% to 1% of the population will have night sweats anyway, kind of called hot flashes. That's just a normal thing. And most of the people with sweats have a non-cancerous cause. So there's a very long list of medications that can cause it, and various other things like that as well. And I would mention there's also quite a number of people we see sometimes have things like obstructive sleep apnea. It's interesting we take a history from them, but the reason for the sweats is things like obstructive sleep apnea. So I've seen that a number of times. Go on to the second case, please. So just a contrast, really, this is a 58-year-old man who's referred with left axillary lymphadenopathy, but he also had lymphocytosis on his bloods with his GP. So that's why he's referred to haematology rather than just the breast team. So we saw him in clinic, noted that he had the lymphocytosis and the GP bloods, and therefore we sent flow from clinic. So for those that aren't aware, so flow is a test you can do on peripheral blood or bone marrow. We're able to look at lymphocytes and various other cells as well and look and see if it's a clonal population. And so sure enough, for him, the flow did pick up a clonal population. So on the day he had bloods. We also did an ultrasound because of the significant left axillary lymphadenopathy. And this actually showed the largest node on the left axilla was 3 by 3 centimeters. So we also got a CT scan the next day. And it reported that all the lymph glands were less than 2 centimeters size in a variety of locations. So when we got the flow result back a couple of days later, he was diagnosed as having CLL. So when we saw him in clinic the following week, we were able to explain to him that we had a new diagnosis of chronic lymphocytic leukemia. He was asymptomatic of it because it was an incidental finding. And we call it stage B because there's lots of lymph glands in a variety of places. However, they're all small volume, 2-3 centimeters in size is fairly small for CLL. And we also see lymph glands much, much larger without needing any treatment. So because he was asymptomatic and had a fairly early stage disease, we elected for active monitoring. And also we need to monitor him ongoing because it's a chronic disease. Next slide, please. So again, slightly different tack here, 28-year-old man, left axillary lymph node. He was referred to us in clinic and we saw him. He had a bulky left axillary node, and then again had bloods and same-day ultrasound. And the difference about this is the ultrasound showed a large 8 by 5 centimeter left axillary node. So we got up a CT scan the following day, which reported no other significant findings apart from the left axilla. And therefore we got a core biopsy a few days later via ultrasound. Obviously we saw him in clinic 2 weeks later for the results of the biopsy. And unfortunately, that occasion, we didn't have the results, which obviously creates quite a lot of anxiety. Unfortunately, we can't, the histology department are very good and they report things as quickly as possible, but they do have a significant bulk of work to do, and they didn't have the result back for us in time when we saw him. So we started to see him 1 week after that. And actually, in this case, the histology came back as sarcoma. So we referred him onto the sarcoma team. So I think I put this case in just an example that actually 28 large axillary node, we thought it was likely to be something like Hodgkin's lymphoma, but actually it proved to be sarcoma. But then we also made the referral onto the relevant team for that. And then to contrast with that, can you use the next slide, please? So we've got a 74-year-old male now, and this is totally different. So this is someone with just abnormal LFTs on bloods. What was noted on his LFT result was his protein, total protein was high. So immunoglobulins and electrophoresis was carried out. And this actually showed that he had a paraprotein, an IgM paraprotein of 10 grams. The rest of his bloods were entirely normal, and he's a very well person otherwise, with no significant past medical history really. So he was referred as a 2-week wait to haematology, and our impression would be this is likely MGUS. And I put this in really to make note of something that Arvind already alluded to. The lab reports that we get tend to say comments like in keeping with a possible plasma cell dyscrasia, MGUS, myeloma, etc. And I really just want to emphasize that actually IgM paraproteins are associated with MGUS and lymphoma. So the reason for referral for an IgM paraprotein really is down the lymphoma route. Do they have any enlarged lymph glands? Do they have any palpable lymph glands? Do they have any B symptoms of any description, really, rather than thinking about bone pain or impaired renal function or other things like that, really. Okay, so obviously we saw him in clinic, discussed everything with him. He had no symptoms, he had no clinical findings, and therefore on the day we're able to say, you've got diagnosis of MGUS. We need to monitor this because it's a chronic condition. It's not a disease, it's not an illness as such. I think it's probably best regarded as a potential precancerous condition, which there are calculators out there to work out how likely someone is to progress. But nevertheless, overall, that risk is very small. So it depends on what type of paraprotein it is, how big it is, etc. But in this sort of setting, I'd probably say the risk is quite low of progression to a lymphoma, but we would monitor it through our sort of clinic service, really. And obviously, depending on where you work, will vary as to what setup there is for that. So can we go to the next slide, please? Okay, so again, put this in a different one. So this is a 63-year-old male. Again, the GP bloods noted lymphocytosis, and hence he referred to haematology as a 2-week wait. So we saw him in clinic and noted that he had no symptoms, nothing to find on examination, otherwise was fairly well. But what was noted is his bloods prior to clinic had actually had flow performed. So when we saw him, we were able to actually speak to him about what we'd found. And this had picked up something called MBL, which is a monoclonal B-cell lymphocytosis. So this is kind of the equivalent of MGUS, if you like. It's a precancerous condition that in a small percentage of people will progress. So his is a slightly unusual phenotype. It was actually closer to mantle cell, but most of them are related to CLL. And in that setting, about 1% of people per year at most will progress to an early stage CLL. So we do tend to monitor these patients, again, through like a nurse-led clinic setting, but it's best regarded as a sort of precancerous thing, basically. Now, what's slightly different with him is actually 3 months later, we've seen in clinic. And in the meantime, he'd been to gastroenterology because he had abnormal liver function and possibly gallstones. And this has actually resulted in having an MRCP, which has shown some borderline splenomegaly. What also changed in the last 3 months, when we saw him first, his blood's entirely normal, but now he developed a mild anemia. So he was sent for scopes because he has a low MCV to investigate for iron deficiency anemia. From our perspective, in particular, mantle cell lymphoma has a sort of predilection for involving the bowel. So we do sometimes see patients with mantle cell lymphoma develop iron deficiency in relation to bleeding within the gut. And when you do biopsies, you often find evidence of mantle cell. So he had further investigations, CT scan, bone marrow, etc. It all confirmed mantle cell lymphoma. And for him, because his hemoglobin was now 105 and dropping, he had a clinical indication for treatment. And therefore, we discussed with him treatment for this. Could we go to the next slide, please? Next case I was going to talk about was a 66-year-old who actually went to A&E with abdominal pain. And a CT scan was performed because of the abdominal pain. And it reported 3-centimeter groin node, multiple abdominal nodes, and a 14-centimeter spleen. So because there's no acute intra-abdominal pathology, he was discharged from the A&E department. I think there was a plan for him to be referred on, etc. But anyway, he went to the GP practice 2 days later, was very concerned, and the GP therefore referred him on as a 2-week wait to haematology based upon his CT imaging. So we saw him in clinic, performed the examination, bloods, etc. The reason for actually going to A&E in the first place is all settled. He otherwise felt very well now. He did a variety of medical conditions, so diabetes, hypertension, current smoker. And therefore, we organised for him to have a core biopsy of the groin node a couple of days later. And also organised for him to have a PET scan as a completion CT / PET imaging, because so far we'd had imaging of the abdomen and pelvis, but didn't have any of the chest. So we just wanted to see whether any significant lymphadenopathy there. Next slide, please. So saw him back 3 weeks later, and his biopsy had actually shown a diagnosis of follicular lymphoma. So in his case, it's actually what we call stage 3 follicular lymphoma on the PET imaging. It was not bulky, so all the lymph glands were fairly small in size. And because he had no symptoms, we actively monitored him. And patients with follicular lymphoma can have a very long lifespan without needing any treatment. A very variable disease. Some people do need treatment fairly early on, but overall, I think it's nearly 20 years now is the average life expectancy with follicular lymphoma. I put a little note here that what would happen if it had been a different lymphoma. So the main lymphomas we look for really are diffuse large B-cell lymphomas, probably about a third of the lymphomas we see. Follicular lymphoma is probably about the remaining third. 5 to 10% are Hodgkin's, and the remaining are all kind of other smatterings of lymphomas, really. So DLBCL will be the commonest high-grade lymphoma that we see, and that's one that we do need to treat. So being that, we were organised for him to have an echocardiogram. Given his cardiac history, we'd referred him to cardio-oncology, and then we'd commence chemotherapy in the form of R-CHOP. So just really to compare and contrast between these two scenarios, you know, the same clinical presentation, asymptomatic, but if it was a low-grade lymphoma like follicular, we just monitor the situation, knowing that he may progress and need treatment, which would involve chemotherapy later down the line, and that would be very effective treatment. But we only recommend it for follicular when he needs it, versus something like DLBCL, which is a high-grade lymphoma, for which we absolutely need to treat when it's diagnosed, or essentially you're talking about palliative care. Can we move on to the next slide, please? Okay, so just want to discuss a little bit now about just change of tack, really. So talking about patients on treatment and when they might go to see the GP, really. So there's probably two main things to think about, really, is patients on just general treatment, so when they're on chemotherapy. And obviously we would encourage them to contact the CCC triage number or our clinical nurse specialists, but they may still go to the GP with a variety of problems. So the common things that we see are constipation with a lot of the chemotherapy drugs. Neuropathy can develop with some of the drugs that we use, and that needs to be managed with neuropathic pain relief and obviously adjustment of the chemotherapy. We often stop or adjust down the dose of the offending drug. Infections, now clearly if someone's on chemotherapy, we'd always recommend they seek emergency care if they have evidence of infections, so high fever, etc. But I'm just saying that might be something they might come to see a GP about. And then the other one is thrombosis. So we know patients with lymphoma have a high risk of having a blood clot, having an active cancer. It's a relatively high risk situation. So again, they might present with a swollen leg or something like that. That might prompt investigations around the TVT route. And then lastly, I put cardiac on the list as well, because I think that we do know some of the drugs that we use can cause cardiac impairment. So anthracyclines, for example. So the gentleman has talked about just before, because he's got high risk factors, we've now referred him to cardio-oncology, and we're quite lucky that we have this service that we've got, the Liverpool Heart and Chest, that we can refer patients for monitoring and management through that. But previously what we do is do echocardiograms and things like that, and there's a risk still on treatment that someone may develop some sort of cardiac complications. So mainly thinking about left ventricular heart failure as a consequence of the drugs that we use. Very occasionally you can get arrhythmias, but that's the main one really, that very unfortunately we do sometimes see people who develop, despite initial investigation, etc., they may develop a cardiac impairment whilst on treatment. So that'd be another factor that might mean that they go to see their GP. And then to go to the next slide. So I think what's probably more relevant is really, because the ones I've just described really is more around conventional chemotherapy. So if you've got DLBCL and you're on R-CHOP, it's a fixed duration of treatment, usually 6 cycles every 3 weeks. They're likely to contact us most of the time. It's unlikely they'll contact their GP. But what is different now is the targeted treatments that we use. So we're using a lot of new sort of what we call novel agents, and I think it's far more likely they're going to go see their GP as a consequence. So it's really just to sort of heighten awareness of these. So in particular, BTK inhibitors, so ibrutinib, acalabrutinib, zanubrutinib, are all drugs that we use quite commonly for CLL and associated with the low-grade kind of lymphomas and various things. And I bring these up particularly because they're not got the conventional side effects that you see with chemotherapy, nausea, hair loss, infection, etc. Actually, the main list of side effects are hypertension, atrial fibrillation, easy bruising and bleeding, headaches, things like that, really. So, and because these drugs are also ones that people stay on indefinitely, they can be on the treatment. Some of our patients have been on them now for nearly 10 years. So these drugs do have associated increased risk of hypertension or atrial fibrillation. So I think it's far more likely that, year 2, 3, 4, 5, whatever, they're on treatment, they're only seeing us once every maybe 3 months at most. But they may develop these cardiac complications of being on these drugs. and need to be managed in the usual way you manage hypertension, atrial fibrillation, etc. Anticoagulation, I think these drugs have effectively an antiplatelet-like action. So we just sometimes describe it closest to clopidogrel. So we would usually stop them pre and post procedures for major operations, maybe either 3 or 7 days either side. So moving on to two other sort of things to mention as well. I think lenalidomide we see more for myeloma use, but we do sometimes use it for lymphoma. And again, it's a drug that people do go on for very long periods of time. It can be for years. And again, lenalidomide particularly associated with risk of thrombosis and infection. And then lastly, I thought it'd be worth mentioning rituximab and then bispecific antibodies, which are new drugs that we're using. So I mention these again because they're often subcutaneous injections. So rituximab we give as subcutaneous injection. We've got collaborators in the communities come and give that in the patient's home once every 2 months. And the risks of that, obviously, it's been around for a long time, are relatively small. But we look at bispecific antibodies, such as one drug called epcoritamab. It's given in a similar way. We wouldn't do it in the community, we'd do it in the hospital. But nevertheless, it's something that's given on a initially quite more frequently, but eventually monthly, and it's ongoing treatment. So I think, if someone was on epcoritamab and year 2, year 3 of being on treatment, these may be new drugs that you may become exposed to, really. And I think it's worth mentioning that these drugs do carry significant infection risk. Okay. So go to the next slide, please. So I think I'll summarize at the end really to say, why should I worry about lymphadenopathy in relapsed lymphoma? And I think I wanted to highlight there's probably two main things to consider. So when it comes to high-grade lymphomas, such as diffuse large B-cell lymphoma or Hodgkin's, then actually we tend to treat them, hopefully get them to remission, and the chances of that are very good for some lymphomas, say Hodgkin's, good, some cases 90% chance of cure. We usually follow them up for 2 years and then we discharge them because the risk of recurrence is very low past that point. It's not nothing, but the risk is very low. So if a patient came to see you and it's 3 years after being treatment, and they've been discharged from us or whatever, then actually a new lymph gland can be quite concerning. They've had chemotherapy, so they're a risk of other secondary cancers as well. So that is a concern, but nevertheless, and irrelevant to that, I think we need investigating for new lymphadenopathy as you would for any new query cancer, really. So I think referral into a 2-week rural service of whatever that may be, going back to the start, really, for these patients. Obviously, we would be keen to know about it, so please do contact us. But I think the main focus is, although they've got a history of lymphoma, say DLBCL or Hodgkin's, they need investigation almost as starting the whole pathway again, because of the whole variety of other possibilities apart from the relapse. And I wanted to contrast really with go to the next slide, please. I want to contrast with low-grade lymphomas and CLL. So things like follicular lymphoma, marginal zone lymphoma, CLL, Waldenström's, all these various terms that we use, essentially they are chronic diseases. Most of these patients have a cancer, a lymphoma, that is effectively a chronic disease. It's not going to go away. It's going to be there forever. Their life expectancy may be pretty much close to normal. CLL now, the life expectancy is almost that of the normal population. But nevertheless, they will have that disease for the rest of their life. They may never need treatment for it, but they will still have it for the rest of their life. And if they're treated successfully, follicular lymphoma, we give them chemotherapy, they go into remission, great, but we would expect them to relapse at some point. Now, that point might be measured in many years, and that may be, depending on the patient's age, may not be a factor of concern, but still we would regard that. So we don't tend to discharge these patients unless, they're very, very early stage, there's a chance of cure, or occasionally for some much older patients where the chances of recurrence in their lifetime is probably pretty low. And I want to also note as well, advanced stage is often monitored until they've got symptoms of bulky disease. So what I'm trying to say is that relapse is something that may be expected, if you like, often manageable and doesn't always need treatment. So the reason I mention all this is because actually in the long-term follow-up, if they happen to come to their GP with new lymph glands, then we would want to know about it and contact it, and then we can see them a bit sooner than previous or a planned appointment, really, because it's almost a potentially expected event that we need to investigate further, if you see what I mean. Okay. So in terms of, bulky disease, last question. So there are various different terms for that, depending upon the type of cancer that they have, lymphoma. So the commonest one is follicular lymphoma, when it's divided into kind of like early stage and advanced stage. And in terms of advanced stage for follicular, it's effectively diagnosed as being 3 lymph glands more than 3 centimeters or 1 lymph gland more than 7 centimeters. So it's a term that we use to kind of split between whether they need treatment or not, really. And then in terms of bulky disease, other lymphomas, so Hodgkin's, it's pretty sizable, either 7.5 or 10 centimeters. Okay. Next slide, please. So the key things I wanted to summarize was that lymphoma can present in a number of, plethora of different ways, really. We're really keen to see the full blood count because it's important for lymphocytosis. The IgM paraprotein I wanted to highlight is something associated with lymphoma, not myeloma. The rapid diagnostic clinic that we have at Clatterbridge, and I think is being set up at other locations as well, offers rapid access to diagnostics to try and get patients to the right place at the right time. And I also want to highlight that low-grade lymphomas are chronic diseases, so try and change the view on that, really. And the last point I wanted to make was about patients who are now on chronic treatments that have been on for years, like BTK inhibitors, where they may go and see yourself because they developed hypertension or something like that as a complication. Thank you.
Thank you both. So if anyone has any questions at all, we do have a little bit of time. So if you want to, people are popping them in the chat rather than the Q&A. So if we keep them in the chat, otherwise I'll miss them. So we have a question about core biopsies and who does those over in Clatterbridge? Maybe yourselves.
No, I'm afraid not. No, so the core biopsies are all done by radiology. So that's the thing. So hematologists, effectively, we can't do biopsies. So it is done by either, well, basically radiology, interventional radiology that does the core biopsies.
Great, thank you. Another question was just confirming that the way that GPs refer to RDS is by 2-week wait. And that's exactly it. Urgent suspected cancer pathways. You've mentioned ENT in the chat, so obviously we refer in the direction of where the lymph nodes are. I had a little question, and that was around some of those. Sorry, Arvin, do you want to come in before I?
Sorry, Debbie, I was just going to say, so the 2-week wait to the lymphoma RDS is still through hematology. Obviously, if you're referring for a neck or lymph axillary, then you send to the appropriate surgical specialty. But for lymphoma RDS, goes to hematology.
Great, thank you. So my query was around, some of these novel drugs and some of their side effects, and there is work going on at the moment at the Cancer Alliance with end of treatment summaries. However, obviously some of these patients are being followed up by hematology for a period of time, and this may happen already, but I'm just wondering if in the clinic letters that it's outlined at all with regards to some of these approaches, the sorts of things that we need to look out for. I don't know if either of you know whether that's something we could look at.
Shall I answer, Jeff?
Yeah, please. Yeah, go on.
So Debbie, thanks for raising that. At the moment, it's not done in a particularly structured way. But actually, as you say, there is a wider piece of work going on at CMCA level about end of treatment summaries. Lymphoma nurses are very keen for us to actually start doing end of treatment summaries in a structured way. And actually, I think when we've got their staffing right, we will they will actually have a dedicated clinic to do end of treatment visits with patients, which will then generate a summary as well. So we're nearly there, but not quite.
That's great. I was also just wondering about the patients that you're perhaps still reviewing on an annual basis, that they're not at the end of their treatment just yet. But whether it's been too much.
Sorry, Debbie, you cut out for a second. Actually, I didn't hear.
Sorry, I was just asking, so the end of treatment summary letters is great, but I'm just wondering with some of the patients that you see on an annual basis, they might present in the interim with hypertension, for example, and we won't realise that that might be linked to their treatment. So it was whether those annual letters or however frequently you review the patients could include that type of information as well, perhaps.
So you're talking about the side effects of chemotherapy that they're currently on, is that what you're meaning? Or
Yeah, it's when you were talking about some of
yeah,
the newer types of medication, because I have to
yeah.
say that if I saw somebody presenting with AF, I may probably would make the connection between that and the treatment that they might have received potentially.
Yeah, I think that's a fair comment. I think we're all learning really with the newer drugs such as the BTK inhibitors. I think we do see them every 3 months, and we do tend to try and do things like check their blood pressure and and ask them questions about risks of atrial fibrillation, etc. But you are right; they may still present to yourselves. Now, having said that, it's always very difficult. Hypertension, for example, is very common as people get older. These drugs we use in older people with CLL, and although the rates are recognised to be much higher when you're on these drugs, the treatment is essentially the same anyway. If you see what I mean. So we wouldn't, well, often we would obviously defer to yourselves in terms of management of the hypertension, but the treatment will be identical to how you would be whether you are on the drug or off the drug, if that makes sense. So though the
Yeah.
drug carries the risk, we wouldn't manage them any differently.
Okay.
Um, Atrial fibrillation, we do sometimes consider stopping the drug, but it's actually only if it's significant AF. So that would be probably something you presented to hospital anyway. If they've got grade 1, grade 2, i.e., they've sort of incidentally been found to have atrial fibrillation on an ECG, but they're asymptomatic, that probably would just be managed as it would normally be for AF, and we probably wouldn't alter the treatment anyway.
Great, that's really helpful. One of my colleagues was asking a very similar question, but also wanted to know, I mean, we're encouraged very much to use the hotline at Clatterbridge for any patients who are on active treatment. But is it useful to contact your teams directly if they're under your care? What's the best approach if we're concerned about something?
So I think the patients are given patients are given those information. If that makes sense. So the patients, when they're sign the consent form, they are given direct contact details for our clinical nurse specialists. Um, but you mean as a GP, whether?
Yeah, as a GP, if we have a patient in front of us and they're not due to be seen for
Yeah.
another 3 months, and there's something that we're concerned about, what would be the best route, I guess.
So Jeff, I could hopefully answer that. So Debbie, there's two broad mechanisms. One is if the patient is unwell, then the triage line would be the right thing. But actually, the patient, as Jeff says, the patients actually have the CNS's direct number. So in fact, you could have to ring the CNS directly from the clinic, or you could ask the patient to ring them. But in the usual way, they don't. They've got the list of numbers. For the specialist nurses, clinical support worker, so that they don't have to navigate their way to the hospital switchboard and all that. So in fact, and patients, ring or text the CNSs, all the time, really. So that's probably the easiest way to get to the right person.
That's great. Thank you. Right, just have a couple of more slides to share before we close. Next slide, please. So really happy that so many people were able to join us today. The recording of this will appear on the Cancer Academy. The slides are already on the Cancer Academy for you to access. Our next webinar is in February, and that's around teens and young adults, which should be really, really interesting. So the link is there for you along with the QR code. And our final slide is evaluation. So really important that the guys who've joined today let us know what you want. We're planning for our webinars and education for next year, and it's really important that you have your say in that, so that we're not delivering things that you don't need. But thank you to both Arvind and Jeff for joining us this afternoon, and really great presentations. And thanks for everyone for joining us. Thank you.
Thank you.
Thank you.